This is going to be a shameless plug, I'm afraid, for a piece of work that I did in this role, which is developed a rapid improvement guide to improve medicines discharge processes for flow. And how this came about was I was asked by my colleagues to describe the sort of things that they needed to look for when we were working with systems. So I was lucky enough to have worked in quite a few systems and sort of understand some of those underlying principles in terms of how pharmacy can contribute to improving patient flow. And I made sure that it was aligned with some of the work that my colleagues were doing in some of the other organisations as well. Can I ask, how many of you here work in acute trusts? Show of hands. How many of you have consistently got pharmacists or pharmacy technicians on board on ward rounds? It was more than I thought. That's great. Okay. So it consists of 5 principles, which somebody did refer to it as not rocket science the other day, which is kind of true, really, but actually there's not always a huge focus on these, so the principles themselves are probably better read as part of the whole document. But really what underpins it is pharmacy services that are close to patients, that are being delivered on wards, that are there when decisions are being made and are part of the decision-making process. And what I have done today is, rather than me bore you by going through all of these, I've actually invited Alistair along today, who is going to talk about his service that very much embodies this way of working. So when you look at Alistair's model that him and his team have built, it very much reflects the principles, and he'll go through how they've done that. So I am actually going to hand pretty much straight over to Alistair to go through that.
Thank you, Amanda. Just adjust the mic. So I'm Alistair Gray. I'm Clinical Services Lead Pharmacist at East Lancashire Hospitals, which is Blackburn, Burnley, Ribble Valley, up in Lancashire. And over the last 3 years or so, we've been developing a model we call Dedicated Ward Pharmacy, or DWP. And what this is about, typically in most hospitals, a pharmacist might cover 2 or 3 even more wards in the course of a day, and they fly around doing discharge prescriptions and ordering medicines for patients, and often not really getting a chance to really influence those prescribing decisions. We know from various studies that the prescribing error rate of hospital doctors is roughly around 10%, and our model is sort of centred on the pharmacists being on the ward round, so they actually intervene before bad prescribing decisions are made. We started off with 1 ward. Over the course of 2016, we went to a 4-ward pilot and then up to 8 wards by November last year. This is phase 1 of DWP. The Trust has invested more, and by Christmas or by December we'll have 24 wards out of our 33 wards delivering the model, so roughly 2/3. And hopefully if our results continue to show sort of good outturns, we'll get phase 3, which is the final phase, where we'll have the model on every ward and enhanced services at weekends so we can influence prescribing decisions. So the way it works, the pharmacist is embedded on a single ward. They take part in the ward round and make sure good prescribing decisions are made, deprescribing happens, the patient's safe, the right medicines to prescribe, antimicrobial stewardship occurs, VTE prophylaxis is adhered to. And then they stay on the ward after the ward round's taken place, so all the tacit knowledge that they built over the course of that period stays with them. They're on the ward 5 days a week, so as various nurses and doctors and therapists change shifts and things like this, they remain there and have that sort of knowledge to make sure they can nudge things in the right direction, so make sure virtuous things happen to the patient. We also have a scheme called Refer to Pharmacy in East Lancashire, which is an electronic referral system that allows us to refer patients to the community pharmacist for post-discharge help with the medicines. I'll talk a little bit more about that in a moment. It's called Dedicated Ward Pharmacy because it's not just the pharmacists. We've actually changed the role of the pharmacy technician as well. So they have an increased amount of time spent on the ward, and they focus on medicines reconciliation on admission, but they also generate the discharge letter, or at least the medicines elements of that. Because the pharmacist is on the round, they make sure the prescription chart is clean. We're still on paper, we haven't gone electronic yet. It means that the technician just needs to get the signal that the patient's getting ready for discharge, so they can transcribe the information from the chart onto the discharge letter. And they're very good transcribers, and that saves time for the junior doctors, and it generally improves the first sort of accuracy of that. Now, everything to date has been done sort of on goodwill and common sense and a modicum of improvement science. But Greater Manchester HSN found out about what we're doing, and it paid for a core team of us to go on an improvement science course. So since June, we've been being sort of ingratiated in the ways of the force. So we've got a driver diagram now, which we're kind of focusing on medicine's reconciliation as part of the project to understand the principles of improvement science. But there's a lot of other measurement strategies we're looking at, things like length of stay, time of discharge, readmissions rates, patient experience, and that's our kind of measurement strategy. And just to indicate that the fact we're really getting into this, we've got a run chart. This is drug histories obtained, and it shows when we sort of introduced the pilot, there was a jump. Then it improved further still as it went live onto 8 wards. And when our project started, we've got a gradual increase. Well, since August, or since September, we're gradually being increased in the number of wards delivering the service from 8. And we're up to about 18 now, and it'll be 24 by the beginning of December. So other things that we've been measuring are things like discharge times. Now this information comes from phase 1 of the pilot, and it shows quite a shift to sort of morning discharges from afternoon and evening discharges. And it's one of the sort of the hidden effects of the pharmacists have been there, dead obviously though it may be. We're there to make sure that the medicines and the discharge letter is ready when the patient is ready to go home. On 2 wards, we've actually been tinkering with the pharmacists actually writing the prose of the letter. And they can only do that because they've been on the ward round and know exactly what's going on with the patient, so they can capture the clinical information. And the people on the round, they know who's going home. They can prompt talks about follow-up arrangements and things which often don't get captured. So we find the quality of the discharge is pretty good as well. It gets checked by a doctor just to make sure there's nothing really obvious missing. Length of stay has come down. Again, this is from the pilot phase. We believe for the 6 wards we studied by about 2.2 days. And we believe this is down to the clinical interventions being made. I mentioned the 341 per week over those 6 wards. The sort of interventions the pharmacists are making are dead simple, but a lot of little things add up. So I mentioned VT prophylaxis. In the very, very first pilot, over a course of 6 weeks, something like 35 people didn't have the VTE prophylaxis prescribed, despite being assessed as being at risk. And they're making sure that occurs. Now we know that there's something like a 10 or 15% chance of someone having a hospital-acquired VTE if they're not prescribed low molecular weight heparin. So by getting that in now, we're preventing harm from taking place, and I think it keeps people in about 5 days longer, and assuming they don't die as a result of a hospital-acquired VTE. It's also things like making sure good antimicrobial stewardship occurs, that IV to oral switches are optimised so they don't carry on unnecessarily, and as soon as you're on oral antibiotics, you've got a great chance of actually going home. But also making sure the right antibiotics being selected in the first place, with the right drug to match sort of formulary choice and the right dose for that particular patient. We've looked at readmissions, and it's quite a kind of a murky picture trying to interpret the data from readmissions. Now, we're putting down a lot of what our readmissions reductions down to the fact we've involved community pharmacists with post-discharge care for the patient. We went live with referred pharmacy back in October 2015, so I've picked a 7-month period for 2015 and the same period in 2017 when we were live. We're referring about 1,000 patients a month from, just to give an idea, we've got 1,000 beds in our hospital. And at 28 days, for the same diagnosis and from medical wards, we've seen a 0.8% decrease in readmissions. And that equates to about 100 patients a year. And Claude Carter reckons it costs about £3,500 per patient. So it's actually really inducing some good savings for the health economy, but also helping improve flow because less people are coming back into hospital. The true figure is probably a little bit greater than that, and we've got Manchester University doing a bit of a study or an analysis of the data because it's quite complicated. We know that the average age of a referred patient is about 78 versus 49 for everyone leaving. The average length of stay is 9 days versus 4 days. So we're referring the elderlier, poorlier, sicklier patients who have got a higher prevalence or likelihood of being readmitted. Some of the other data we've discovered in the period March to October when we introduced some new outcome captures, we'd refer nearly 5,000 patients It saved community pharmacists 154 hours. 87 patients had unintentional GP prescribing errors identified because the community pharmacist had access to the patient's discharge letter, and they were able to rectify that. And 394 items weren't dispensed net as a result of knowing what the patient had come out of the hospital on, but also by the fact we were sending hospital admission notifications as well as discharge notifications, so they could pause the dispensing process while the patient was in hospital. And I think that's it, actually. So, any questions?